the medical-centered home is definitely the way we need to be going, but we cannot club that with the cost factor going to go down necessarily. So that is the difference I want to make between the two systems. We are adding on an extra tier, which is needed, which is necessary. But to imagine just because we have this extra tier, we are going to be cutting down the costs, maybe eventually going out 5 years and 10 years, we might reap the benefits. But for us to think on a short-term basis, within a year, within 2 years, we will be seeing a reduction in the cost is not being realistic at all. It is only when those patients are constantly educated that your diabetes is out of control, you need to do this, you need to do this. Down the line, 2 years down the line, 5 years down the line, we might see. But to expect something right around the corner is very unrealistic. So for us to think that just because we have a medical care home, the cost is going to go down is being unrealistic. The cost actually will go up because we're adding on a tier. It's needed. I'm not saying that the tier is not needed. That particular tier is absolutely necessary. It is one more person in our practice. It's 2 more people on the floor of a hospital floor and a whole array of people working in the hospital to provide that particular service. So cost definitely is not being contained. It could be eventually, but definitely not on a short-term basis. And on the other concept, if I might, the capitation model has been tried out. And this was done by insurance companies. This is done by professionals. This is what they are in for. They are in for profit. And they were not able to do that. The system didn't work. It didn't work with the physicians. It didn't work with the patients. Nobody was satisfied. The insurance companies didn't make out well at all in the particular program. As we know, the whole thing fell apart. So for us to think that what insurance companies were not effectively able to do and accomplish, a state-funded program would be able to accomplish with our limitations, I find that very difficult to believe that we would be successful in taking over a role for which we have no experience at all. So I'm very concerned when the state becomes the provider of health care. We don't have to look too far. If you just look across the other side of the pond, look at the status of Great Britain, look what's happening in Canada. All of them have government-run models. And what is the net result? Total failure. Total failure. People have gone back to private insurances. People have gone back to the previous systems that they had because that is the only system that will work. Look at our own Medicare. I dread the day that I'm going to turn 65. And that's not too far away, because who is going to accept me? Which physician is going to take Medicare patients is a big concern that each and every one of us have because of the way the Medicare reimbursements are. And I'm sure all of you follow this at the federal level. Every 6 months, you know, the bill is given a life for another 6 months and another 6 months. That's how Medicare is being held at this point. So these models have to be reviewed before we take on this task of trying to deliver health care to our residents here in Connecticut.